I'm going to hit record.
Okay, perfect. Let me try it one more time. Okay, so you could see the slides now?
Yeah.
Okay, awesome. So, so what is the concept behind lung volume reduction? So we think that patients with severe emphysema will have air trapping, and the air trapping will cause some of the mechanical problems pertaining to the diaphragm and the intercostal muscles. And specifically, we think that the diaphragms move caudally, they move down. And they're classically on a chest X-ray, you see the flattening of the diaphragms and the hyperexpansion of the rib cage. And it has been shown that this puts a patient at a mechanical disadvantage in terms of their breathing mechanics. And so this is I always tell patients that this is a separate problem from an actual FEV1 lung function. So you have poor lung function, but more importantly, you are also mechanically disadvantaged. And so when we talk about lung volume reduction, the goals of that procedure is to restore some of the flattening of the diaphragm and the hyperexpansion that we see. And it also happens to improve the FEV1, but that is not the main goal of the procedure. Now, it has been shown, and I'll show you as well in the next couple of slides, that there's improvement in VQ mismatch, and that is probably the mechanism behind improving someone's FEV1. And as we have seen in our own practice, getting people off of oxygen that are chronically on oxygen. So most likely it has to do with the VQ mismatch improvement. And here are just some of the schematics that show you a successful lung volume reduction where the diaphragm moves up and the patient is less hyperinflated. So there's been some interesting data using a SPECT scan, a SPECT perfusion scan rather, that is able to show us what happens before and after valve placement. And essentially what happens is that you are redistributing blood flow away from the destroyed lung that's not perfused to other areas of the lung that are better perfused. And we haven't done trials ourselves, but we have seen this anecdotally in our patients who have perfusion scans before and after the procedure that this actually works. And it's interesting because let's say you treat the left upper lobe, you will see more perfusion to the left lower lobe, but you also see more perfusion heading to the right side. So it's really on both sides. And hopefully the other lobes are more healthy. So now you're sending more blood flow to the healthier lobes, and that's how you improve the VQ mismatch. So these are just some of the interesting colorful schematics looking at the perfusion and ventilation scans using this SPECT VQ scan technology. And so green is going to be VQ matching, red is mismatching. And as you could see that after a successful valve procedure, you're able to decrease the red and increase the green, so to speak, right? So you're able to decrease the VQ mismatch. You're able to shunt more blood flow away from the destroyed lung to the healthier lungs. So this is a nice summary of the history of lung volume reduction. And the first thing you notice here, that over a 20-year period, there has only been one trial that looked at surgical lung volume reduction. And that is the famous NET trial in 2003, New England Journal. That is the one that showed that there's a subgroup of patients that have poor exercise tolerance, upper lobe disease, heterogeneous emphysema. And that is where you see the benefits of surgical lung volume reduction. And then in contrast, you see that there's been a number of valve studies. Now, this slide is from the Pulmonx company. That's the company that made the Zephyr valve. So that is why all of these are Zephyr trials. There has been at least one major spiration trial. That's the other valve, which is made by Olympus company. So half a dozen at least of valve studies. And what's nice is that they have tried all the different possible combinations to really try to understand who are the patients who benefit from this technology. And so We have tried upper lobe, lower lobe, homogeneous, heterogeneous. Presence of collateral ventilation, this is extremely important. We'll get to that in a second. Basically, collateral ventilation means that there is communication between the lobes, so that if you put valves, if you try to close a lobe that is communicating with an adjacent lobe, then the procedure is not going to work. And so this is very nice because it really helped us flush out who the right phenotype is for the patient. So I wanted to go through the Sentinel trial, which is, I think, the one that you should be familiar with, and patients ask questions about the procedure, and you can always reference the data from this trial. And this is the Liberate trial, which was published in the Blue Journal in 2018. That is sponsored by the Zephyr, by the Pulmonx company, using Zephyr valves in patients with heterogeneous emphysema. The primary objective of the trial was to demonstrate improvement in FEV1 by more than 15% between the two groups at 12 months. 190 patients. This is actually the largest trial that was conducted with valves, with a 2-to-1 randomization. And as you can see, that the trial nicely hit that primary endpoint, where there was 47% versus 16% of patients who demonstrated an improvement in FEV1 at 12 months follow-up. These are the secondary endpoints, which were all also positive clinically and statistically. And I want to highlight that because sometimes educated patients will ask you, if I go through this procedure, how much further am I going to walk? What am I going to experience? So you could reference these numbers: 17% improvement in FEV1, which is about 104 cc's. 6-minute walk test went up by 39 meters, and the St. George questionnaire went down by 7.1 points. So just as a reminder, we always talk about statistical significance, clinical significance, right? So clinical significance is what we care about. In terms of clinical significance, the SGRQ is 4. So that is more than clinically significant. And in the NET trial, which was the surgical lung volume reduction, the SGRQ was 8 points. So this is close to that. And then the 6-minute walk test, same thing. That is clinically significant. It's a marginal improvement in FEV1, but I can tell you from my own limited experience, these are patients who are very sensitive to even small improvements in FEV1. So if you could give them that 18% improvement, that could be a tremendous quality of life difference as well. So we have to talk about complications and things to watch out for. This is what we tell all of our patients as soon as we start talking about the procedure, is the fact that they may experience a pneumothorax. So what is the mechanism behind the pneumothorax? Well, if you think about conceptually, let's say you're putting a valve in the left upper lobe, you are successful in causing atelectasis in the left upper lobe, you are then going to hyperexpand the left lower lobe. And in doing so, the tissue may stretch and you may tear and you may cause some parenchymal leak, which is really what a pneumothorax is. So a pneumothorax is thought to develop from a hyperexpansion of a adjacent lobe, which is actually a sign that the procedure is working, right? I mean, you cannot get a pneumothorax if you didn't have any lung volume reduction. So some of our success patients are the ones who develop pneumothorax during their initial couple of days of the procedure. But it's very important to be aware of this complication because, first of all, if this happens, it'll happen in the first couple of days. And that is why we keep all of our patients in the hospital for about 4 to 5 days after the procedure, because we want to be there if the pneumothorax occurs, and we educate all of our staff to make sure that we're prepared to deal with the pneumothorax. The incidence of pneumothorax in the Liberate trial was 34%. So 1 out of 3 will develop a pneumothorax. Patients leave the hospital with a bracelet, either on the right arm or the left arm, that says pneumothorax alert. And we tell them to go to the nearest ER if they develop any sign of chest pain, shortness of breath, so that everyone should be aware that they have valves and they may develop pneumothorax, although the incidence is very little after the first 3 days. Okay, So that's the pneumothorax right there, 34% in the patients for the first 45 days. Let's talk about some of the other problems. So you may think that pneumonia. What if a patient gets pneumonia from the valves? Can valves cause pneumonia? Well, actually, literature shows that it's very rare. Actually, only one patient had pneumonia. But also conceptually, you shouldn't really get pneumonia, right? Because valves aren't plugs. So if you plug a lobe, you will get pneumonia right away. Valves open and close, so they allow you to ventilate secretions and air. And so pneumonia is very rare. And we have seen that be reproduced in other trials, including the Spiration trial. COPD exacerbation, usually not a big deal, something you could easily handle. We haven't really sent anyone into respiratory failure. But again, that has to do with careful patient selection, which we're going to go over. Now, the real elephant in the room here is this first complication, death. Why was there a mortality? Which is very unusual to see a mortality in a device trial like this. This actually has not been replicated in those numerous other valve trials that came before Liberate. So there's something unusual that happened here, and why we lost 4 patients. And the reason why there was a mortality is because, remember how I said that the pneumothorax can happen in the first 3 days? Well, the reason this wasn't always recognized. And so what happened is that in the clinical trial, patients were allowed to leave the hospital in the first 24 hours. And then they developed out-of-house pneumothoraces, and all of those mortalities were out-of-hospital pneumothoraces that unfortunately patients didn't make it. So it was very unfortunate that this happened, but also it was a learning point for everyone. And as soon as they realized this, they immediately changed the protocol, and from that point on, there was no more mortality. And so obviously, one can also then say that if we had known that from day one, or we had appreciated this from day one, then these patients wouldn't have been lost. So it is tragic, but it allowed us to now know how to properly take care of these patients in their post-procedure period. So moving on to indications and patient selection, I think this is super important. And if anyone wants to take a screenshot of this, and you'll get the recording as well, and I can also send you these slides. But this is a cheat sheet on how to, when you're sitting in your office and you're seeing patients, how do you remind yourself about this particular option for patients with COPD? So FEV1 has to be less than 45% predicted. As you know, FEV1 is going to be the same regardless of how the PFT is performed. So that is your first sort of first cut, is 45% or less. Patients could be heterogeneous or homogeneous. So the Liberate trial I just showed you was heterogeneous, but I'll show you another trial which was for homogeneous patients, and the FDA approval for the Zephyr valve is for both groups. Okay, so you could sort of forget the upper lobe predominant emphysema, teaching, the classical teaching that has been sort of propagated and instilled into us. That is true, but that is only for LVRS patients, surgical lung volume reduction. That is no longer applicable for valves. If you want to consider somebody for valves, then we put them in lower lobes, upper lobes, heterogeneous, homogeneous. All of those are approved. Now, residual volume has to be at least 150%, preferably 175 or higher. The most important thing I'll say here is that the residual volume is determined only in the body box. If you don't have a body box, then forget the RV, because it'll be artificially low. And so don't exclude a patient on the basis of a falsely low RV because the test was done with another method. And the practical point here is that not everyone has access to a body box. Actually, out in the practice and community, you don't have that access to it. So I tell those pulmonologists, if you have someone with clinical emphysema, they're symptomatic, FEV1 is less than 45%, we're happy to sort of formally evaluate them with all these other technologies. Now, diffusion capacity more than 20% was adopted straight out of the NET trial, because in the NET trial, DLCO of less than 20% was considered to be a marker for increased mortality. But as all of you know, diffusion capacity, it depends on patient effort. So a patient with bad COPD may not muster the effort, and you may get artificially low numbers that don't make any sense. I will show you a case later on, one of our success stories, whose diffusion capacity was 2%. Obviously not realistic, but so just take the grain of salt. Patient has to be able to walk 150 meters, but less than 500 meters, right? So you really are looking for someone with the Bode index of, or I'm sorry, the MMRC of 2 to 3. Non-smokers in clinical trials, they were supposed to be non-smokers. Negative collateral ventilation. So I'm going to show you how we look at that, which is really important because there should be no communication between the adjacent lobes and the target lobe. Otherwise, you won't get lung volume reduction. Now, exclusion criteria are pretty common sense. Can't take anyone who's actively infected, actively exacerbating. But here are the ones that are important for you to know. So anyone who had lung surgery, segment or lobe, would be considered thoracic surgery. You really shouldn't put valves on that area. You may put it on the opposite lung, but the reason is that they're going to have a lot of adhesions, and you may not develop atelectasis. Now, if someone had a wedge resection, it's a discussion with the patient, but technically those patients are excluded. If someone had talc pleurodesis, obviously you're not going to get atelectasis, so those are excluded. Patients that are hypercapnic, PCO2 considered to be more than 55. So this is why, when you properly select the patient, those patients should go through anesthesia without problems. And that's kind of the importance. Now, if you have a big bullous emphysema, really you should think about bulectomy. Those patients will do very well with that. A couple of other things to know. Spiration valve is only approved for heterogeneous emphysema. That doesn't mean that we don't use it for homogeneous, but technically you shouldn't. And then the Zephyr valves are not approved for alpha-1 patients, but spiration is approved. So again, this is from a practical standpoint. I have a couple of alpha-1 patients who got valves, and I've used both valves. But just so you know, for your own knowledge, these are the sort of the inclusion exclusion criteria. And if anyone has any questions, just feel free to jump in. So these are some of the differences between bronchoscopic and surgical lung volume reductions. Obviously, surgery is done with VATS. It's interesting that the NET trial in 2003, what percentage of patients had VATS back then? It was about 25%. So 75% of patients had median sternotomies with apical wedge resections, right? So always sort of interpret the data from the NET trial with a grain of salt, because that is ancient technology compared to what's happening now. So we do all of our LVRSs with VATS, but we do respect the NET trial conclusions. So we will not do VATS LVRS on a homogeneous patient or a patient with lower lobe disease. Obviously, VATS is irreversible. VATS does not require presence of a fissure, right? Whereas a valve, you are dependent on the fissure, but your inclusion criteria is much broader. So there's something called a Stratix lung report, and this is very useful when you think about valves. And basically, what this is a report that's based on a computerized analysis of the patient's CAT scan, where a software algorithm is able to provide us the following data. We know how much emphysema there is in each lobe. We know if the fissures are intact, and we know the lobar volumes. And so we can use this data to figure out where the valve needs to go. Conceptually, the valve should go into areas that are most destroyed, most hyperinflated, and areas that are that have a complete fissure, meaning that areas that are not communicating with each other, right? The destruction or the emphysema scoring is done by looking at Hounsfield units, and the computer says that any voxel that is less than 910 Hounsfield unit will be counted. So negative 910, negative 920, 930, all the way to negative 1000, right? And then you see how many of those voxels you have. And if you have less than 50% voxels that are negative 910 Hounsfield units, that is white collar. That basically means no insufficient emphysema. Those patients were not included in clinical trials. Anything more than 50%, you get 50 shades of gray, and you have and those patients were included in clinical trials. So if you are more than 70% voxels, then that's black, gray, light gray, or white. Okay, so you could look at the color and get a sense. But if you use a different cutoff, like if you use 950, then the cutoff becomes 30. And some expert pulmonologists who do this think that perhaps 950 is a better cutoff to use than 910. Maybe that's a little more sensitive in terms of patient selection. We talked about collateral ventilation. All right, so this is the concept of collateral ventilation. We look at the fissure carefully ourselves. We always review it with one of our thoracic radiologists to better understand who has a complete fissure, who doesn't. But ultimately, you cannot look at a CAT scan and say that someone has a good fissure, and therefore I'm going to bring him in for the valves, or I'm going to exclude them. Because as it turns out, there is a lot of overlap between having incomplete fissure and actually physiologically not having collateral ventilation, and vice versa. So it is not a perfect, it's not a one-to-one correlation. And we use a Chartis system, which is a device that I'm showing you right here, which basically allows us to measure collateral ventilation or measure flow, and be able to physiologically show if someone's fissure is intact or is it interrupted. Okay, and this is the only way that that patients should be properly selected for the procedure. And I'll show you examples of fissures that were 100% complete that were physiologically interrupted, and vice versa. So what we do is we go in with the bronchoscope. We use this catheter that is sort of like a Swan-Ganz catheter. It's got a balloon. It's got a little flow. It's got a little sensor that measures flow. You inflate the balloon in the lobe that you want to treat, and then you want to see if there is collateral ventilation. In other words, you want to see whether or not you have persistence of flow, or does the flow disappear. So this is expiratory flow. With the balloon inflated, the flow disappears, and the resistance, right, the airway resistance goes up nicely, right? So what does that mean? That means that the fissure is intact, because when the lobe is obstructed by the balloon, you have no flow. On the other hand, here, this is CV positive, collateral ventilation positive, right? You have persistent flow, even though your lobe is occluded. Why? Because the flow is traveling through the fissure that is interrupted. And that is the only way you should select patients. So here's a very nice study out of Germany that looked at over 100 patients, and they looked at who has complete fissure, defined as more than 95% complete. And then you bronchoscope all these patients, you do a Chartis. And if you look over here, this is actually quite incredible, that almost 20% of patients who were more than 95% complete on a CAT scan actually had positive collateral ventilation. So if you treated all these patients, then 20% of your patients will have no atelectasis. And those numbers evolve as you go down. So for our, in our protocol, we will take patients that are 80% and above. We will give them the benefit of a doubt, and we will bronchoscope them and perform the Chartis assessment, but only put valves in those who are proven to be CV negative. So this is the summary of the evaluation. You need to get PFTs in the body box. You need to get a room air blood gas. You need to get a 6-minute walk test. A CAT scan has to be done with thin slices, because that's what's required to generate the StratX report. Now I'll show you some perfusion scan data that's very important for patients with homogeneous emphysema. We want to rule out pulmonary hypertension and have those patients go through rehab. So these are the valves, and there is some technical differences between the valves. I think one of the features of my program that I think is a strong feature is the fact that we use both valves. We actually have them both sitting on a shelf, and I will place valves side by side from all these different companies, because I found that there are different situations in which one may do better than the other. But in general, from a technical standpoint, when you deploy the Zephyr valve, you put the catheter up against the distal carina, and the valve is deployed against the distal carina. And that's what keeps the valve from sliding down, because it doesn't really have any other way of staying in place other than being rested onto that carina. When you put in a spiration valve, it's actually a little bit easier, because all you do is you just line up the catheter with the ostium of the lobe, and you deploy right there. And the spiration valve will stay in place because it's got little hooks that will kind of dig into the mucosa. Whereas the Zephyr valve stays in place because of the distal carina, and also it's got some radial force right over here at the body of the valve. And here's an example of a case, patient who has spiration valves here, and it has a Zephyr valve right next to it. And that was one of the patients who did very well. And there's a couple of interesting bronchoscopic images just to show you that spiration valves tend to settle, so they will kind of migrate distally a couple of millimeters. Here's a couple of weeks apart. This valve looks like it's about to fall out, but actually it settled in very nicely. Here's an example of a valve that is oversized, and so you see some kinking. If there is kinking or wrinkling, you have to remove the valve because it's not going to be occlusive. You just put a smaller size. Here's an example of a Zephyr valve where the duct bill is open, and it actually stays open, it doesn't close. So what's happening here is that the valve is oversized, and it needs to be removed and replaced with a smaller one, right? Because the duct bill should open and close. Here's an interesting example, a patient of mine. This is in the right upper lobe posterior segment. We placed the valve. She didn't close, and then I brought her back for repeat bronchoscopy, and I see that there's an airway right next to it. And I said to myself, I can't imagine, I can't believe I missed an open airway. That's almost impossible. But so it's a good thing we take pictures. I went back and I didn't see an airway. So this was bronchospasm during the procedure, and we obviously didn't see that there was an airway there because patient bronchospasm. So then we revised the valves, and she did well. Here's an example of atelectasis. However, this is not a good atelectasis. This is basically lobar atelectasis, but the way you want it to look after a valve procedure is, I don't know, hopefully you can see the video. You see, it looks like a thin pancake. So that is, that actually is the way, that is the way that a CAT scan should look. This is for left upper lobe, believe it or not. It looks like a tiny little pancake. And everything else that you see is left lower lobe. When it looks like this, that basically means that there's post-obstructive pneumonia there, and there's a lot of mucus coming out of the valve. So I want to show you an example of a patient whose FEV1 was 36% predicted, her residual volume was 171, 178, diffusion capacity 2%. So obviously that was not well performed. This is a StratX report, and just to point out the fact that she has heterogeneous emphysema. The right upper lobe is very destroyed. It's black color because it's more than 70. The left upper lobe is also very destroyed, a little bit less, 63%. Okay, so a little less destroyed, but it's remarkable how heterogeneous she is, right? Because the lower lobes are completely normal. You have over 2 liters of volume sitting in each of the lobes, so very hyperinflated. You see that the minor fissure is interrupted. Okay, so you cannot put valves in the right upper lobe right? Because you have collateral ventilation here. The left fissure is 93%. And if you, and the little slide I showed you with data from Germany, you know, you definitely need to interrogate that fissure with the CHOTUS because it has a probability of being CV positive. But if this fissure was intact, then this would be a good option for either valves in the left upper lobe or surgical LVRS to the right upper lobe, right? So that is how we think of a patient. We don't try to convert everyone into valves, but it's really both options are on the table for the patient. And so, but you know, all things being equal, I do certainly gravitate more towards valves because it's less invasive. So we brought the patient in, we inflated the balloon in the left upper lobe. This is a 1 minute mark. And you could see that what happens here in about 40 seconds, you basically, the flow stopped. And then as soon as the balloon came down, the flow came back nicely. So this is a very nice CHOTUS assessment that proves to you that the left fissure is physiologically intact, and therefore you could put valves in the left upper lobe. So here we are with doing the CHOTUS assessment, and now these are the different sizing catheters we use, and we are placing valves. And so this is the left upper lobe lingula. There's a Zephyr valve sitting there. You can see that there's an open ductile that opens and closes. Using a combination of valves, I think put 3 valves here, 1 in the lingula, 1 in the interior segment, and then 2 in the apical posterior segment. So total of 4 valves. And you can see that the posterior segment of the apical posterior is a difficult segment for Zephyr valve because you can't really, it comes off at an angle, you can't really get the scope in there. So that's why this segment received a spiration valve, and then the other segments received Zephyr valves. The patient did very well. And I want to show you that on a chest x-ray, this is what the Zephyr looks like, this is what the spiration looks like, so you can tell which one is which. And a few days after the procedure, this is what happens to the left upper lobe. You can see the left upper lobe is starting to close, and here it looks like a little sliver. So on post-op day 4, before patient went home, this is a chest x-ray. Remember we said that the procedure aims to improve the respiratory mechanics by elevating the diaphragm. So you can see the diaphragm came up about 9 centimeters. So that is a very incredible improvement. And these are her PFTs 3 months later. So as a reminder, her FEV1 improved 16%. So it went from 43 to 57% predicted. She gained 145 cc's. The residual volume decreased by 1.1 liter, which was a 34% reduction. So now the residual volume is 112 instead of 175. This is her diffusion capacity. And the patient was very happy. She actually is oxygen independent now. And she wrote us a very nice memo. She's also on our website. So she did very well. So I'll show you a couple of examples just as a, just to kind of stimulate the thought process. What would you do in this case? So this is a patient who has destruction in the right upper lobe only. Left lung looks fine. Right lower lobe looks good. Can you put valves in the right upper lobe? The answer is no, because the fissure is interrupted. So this patient would be evaluated for lung volume reduction surgery, LVRS, of the right upper lobe. This patient here, if you have 2 lobes that are more than 70% destroyed, so black color, 2 lobes in the same lung, that patient is excluded from lung volume reduction because they have too much emphysema. There's no good lung left, and the risk would be quite high for this patient. So these were excluded from clinical trials. Obviously, lung transplant would be probably the only viable option here, as well as rehab and medical therapy. How about this patient? Well, this patient, as you can see, has a lot of destruction in the right upper lobe, but when you look at the CAT scan, the right upper lobe is basically one big bulla. So this patient would be a bulectomy patient, as opposed to valves. So again, those are some of the patients. Now, I just want to switch gears and talk to you a little bit about homogeneous emphysema, because homogeneous emphysema has never been part of the discussion until the valve technology came out. Right, in the NET trial, it was always heterogeneous, and the clinical teaching for us as pulmonologists for years has been homogeneous is not appropriate. However, as I told you earlier, valves are approved for homogeneous emphysema. I want to show you a trial. This is actually only one trial which was done. So I always tell my patients that everything that we know and whatever I tell you is based on one clinical trial. It's called the IMPACT trial, and this trial was consisted of 93 patients with a one-to-one randomization. These were homogeneous patients. And what I want to show you here is that if you look over here, residual volume, these patients were very hyperinflated, as you can see. And so the minimum residual volume that we want to see is 200% for homogeneous patients. Okay, so those patients have higher RVs than the heterogeneous patients. Everything else is about the same in terms of the selection criteria. These are two very helpful slides that show you what happens at 3 months follow-up. And basically, you could see that standard of care group versus the valve group. Okay, you have improvement in your FEV1 by 120 cc's. Okay, so similar to the Liberate trial. You have statistical significantly improval in residual volume reduction, 6-minute walk test. So 40 meters, okay, identical to Liberate trial. SGRQ went down by 9 points. So that's pretty impressive. And then the other things are over here as well. So these were statistically significant. What about FEV1? The same thing, okay? So this just looks at MCID of 15% or 12%, MCID of 100 ml. So again, remember, when we talk about clinical significance, we talk about MCID, minimally clinically important difference. And as you can see, you hit all of those points with a very nice p-value. So that is the reason that FDA granted approval for Zephyr valves, because this is a Zephyr sponsored trial for homogeneous patients. Interestingly, they didn't have any mortality. They actually had 1 death in the medical group, and they had the same amount of pneumothoraces, pretty much. So I don't know. To be honest with you, I'm not sure what their protocol was in terms of observation, but they didn't have any mortality. So again, that just goes to show you that the mortality is something that's entirely avoidable. So this is a patient who actually came from your group. Yeah, when obviously disclosing names, but this is one of the patients from Stony Brook that I helped take care of. And this patient, as you can see, has homogeneous emphysema. Now, you notice that this graph looks a little different than the others. This is from a spiration company, not from the Pulmonx. So this is not called the Stratix report, it's called Select CT. But basically, they use a similar software. And what's interesting is that they use slightly different cutoffs. So those guys, the Pulmonx guys, use 910 Hounsfield's units, and these guys use 920 Hounsfield's units. And because they use 920, their minimum is set a little bit lower. So it's 40, not 50. So anything more than 40 will get a score. And as you can see here, 47, 48, 51, 53. The point is that these numbers are very similar to each other. So therefore, this is homogeneous emphysema. The fissure scoring, right? Now, this is obviously, this tells you that the fissure is completely interrupted, 8%, 13%, there's no fissure. But this just goes to show you that this patient is someone who we knew that this number is false because we looked at the actual CAT scan ourselves and I saw that the fissure looks okay. So again, just to show you that you cannot rely on these reports, you always have to look at it yourself. But there is an additional step that is very important that I wanted to go over, which is called perfusion, right? So we get a perfusion scan, not VQ, not ventilation perfusion, because we don't care about ventilation at this point, but you want to see what is the perfusion. And as a lot of you are aware, when do we get perfusion scans usually? Well, we usually get them for patients who go for lung surgery, and we want to sort of risk stratify them. And the traditional perfusion scan will give you zonal perfusion, right? You got top zone 1, 2, and 3. And this is the traditional perfusion scan for this patient. The reason why we're getting a perfusion scan on this guy is because how do you know which lobe to put valves into? I mean, this is homogeneous emphysema, so you can use the perfusion scan to help you make that selection. And according to this perfusion scan, you can tell that the right lung is getting 2/3 of the perfusion, the left lung is only getting 1/3. So that's somewhat unusual, but you have sort of a nice differential there. So then the question is, do you put valves in the left upper lobe or left lower lobe? And it's very hard to tell because on the left side, we have 2 lobes and we have 3 zones. And what is the relationship between lobes and zones? And even on the right side, we have 3 lobes, but obviously the middle lobe is the small lobe, but the zones are equally spaced apart. So the zonal perfusion is really not helpful for the purpose of what we're discussing. It is helpful for the surgeons, right? Because what is LVRS? LVRS means that you basically take out zone 1. So that is usually zone 1 and right upper lobe apical resection. That usually corresponds quite nicely. But for us, we're taking out the whole lobe. And so we need a better system. So luckily, my hospital recently acquired a SPEC VQ scan. So those, remember in the beginning of the talk, I showed you those colorful pictures of the VQ and the perfusion. So we have that now, thankfully. It's been incredibly helpful to have that. And I wanted to demonstrate that to you here, because on a lobar perfusion scan, now we can get perfusion for each lobe. So the total numbers are similar, but look at this: left upper lobe 26%, left lower lobe 4%. And that means that this 17%, which is the middle zone, was lingula, right? And you never would have known that if you didn't have this lobar perfusion technology. So obviously, when you see 4%, that left lower lobe is useless. And here's what it looks like. All right, so it's kind of like a heat map with different colors, and you can see that this is the guy's left lower lobe, and it's completely black. There's no perfusion at all. So that was very helpful. This is probably where the lingula is up here. So he was treated with left lower lobe valves, and clinically did incredibly well, exercising, running, off of oxygen. I haven't, this was a recent case, so we don't have 3 months PFT data yet, but I'm sure his numbers are going to look much better. And he had a nice radiographic response. There's a lot of like social media that's associated with lung volume reduction, just because patients are the ones that are finding doctors nowadays because they read a lot of stuff on the internet. This is my cell. You guys can call. Some of you already have my contact, but call me anytime. And this is just my office info. But I wanted to stop here so that we can ask questions. Thank you.
Thank you very much, Dr. Shostak. I have a question. You showed in the middle of your talk, you showed a left upper lobe that was atelectatic with a valve that you didn't like the way it was in there. I was wondering if you could review that again, because it did seem like you were able to get the lobe to be atelectatic. I don't really understand what was wrong with the position.
Is this the slide?
Yeah.
This patient, I was concerned about this patient because I'm gonna play this for a second. This is a different patient. You know, you want to see the best CAT scan or the best X-ray that is the one where there is a thin sliver of a lobe. In other words, here, this to me looks like you have, yes, you do have left upper lobe atelectasis, but that left upper lobe is filled with something, mucus. Obviously this could be
I
a
see.
tumor.
So it doesn't have enough volume loss.
Right. So the lobe is down, but it doesn't have the appearance. I'm just trying to see if I have an X-ray of the patient I showed here. So, like for example, if you look here, this is a great looking at, because here you really have a thin sliver, right? You could see that there is tracheal deviation. There is obviously hyperexpansion of the lower lobe, but there is very little left of the upper lobe. It almost looks like a thin pancake, and those are the best ones. And so that's why on that other case, when I went back in and I bronch her, there was all that pus that came out. So you could see that there's a difference, even on a chest X-ray. You could appreciate that there's different appearance of the lobar collapse.
Okay, thank you.
It's usually going to be also accompanied by classic signs of post-obstructive pneumonia.
Do you think the reason for that was that there was something wrong with, why should that one?
Yeah, trying to remember the specifics of the case. It was a long time ago. I think it had to do with either with positioning of one of the valves that I thought maybe okay, but probably in retrospect I was wrong, and that valve needed to be repositioned. I mean, typically it happens when the valve is not able to open and close, right? Because the reason that you don't have post-obstructive pneumonia in every patient is because the valve is able to ventilate. It opens and closes, and so if the valve is oversized or if it's obstructive and that mechanism, isn't happening, you will get post-obstructive pneumonia. And again, it's amazing that in multiple clinical trials, the incidence of that pneumonia was a couple of % only, right? Because you would be concerned that the number would be higher, but it's actually not. So in that was the only case in my practice that I've seen this happen to. So I think it's still rare, but probably related to the way I put the valves.
Dr. Shostak, could you bring up the slide that showed the flow dropping down and then the resistance going up for the Chartis? Right. So do you see a lot of variety in the amount of time? In other words, can there be a very slow, long downflow if the collateral is minimal in amount?
Oh yeah, absolutely. It's a good question. So over the last 2 years, as we've gotten more comfortable with this entire program, I have noticed that you can actually correlate the amount of time it takes for that flow to go down to how complete the fissure is. And so if you have a perfect fissure, you will see what you have on the screen. But that is an exception. That's not the rule. The rule is that you should wait for 8 minutes. The average, I would say, is 8 minutes. 8 minutes. Yep. So in other words, you should stay there with the balloon for 8 minutes maximum until you either give up or you move forward. So the typical one that I've seen is maybe 2 minutes, 3 minutes. But I have seen fissures that were, you look at it and you say, well, I think I see a small interruption in one area. Mostly the fissure looks fine. It's over 90%, but I'm worried there's a small interruption. You bring the patient in, you inflate the balloon, and guess what happens? You have a very nice slow decrease in the flow until you get down to about 10%. And that's sort of when the rubber meets the road. It's when you get down to 10%. Because you really needed to go down to single digits. 6%, usually we say 6% is good enough. But you will usually get stuck at around 10% or 12% or 9%, and it'll just persistently stay there. It'll never go down to 0. And that is because of that small gap. I've seen that many times now.
And
so, yeah.
Did you say that there are some that where they look visually as if they are fully intact, but then when you do this test, you'll find that
Yes,
there is collateral?
yes, yes. Well, I have had patients with 100% fissure who could not get a procedure.
Interesting.
And at the same token, I had one guy with 80% fissure. And I said to him, don't even bother. This is not going to work. But, you know, strictly speaking, we go 80% and above. So I gave him the benefit of the doubt. He was okay with that.
Right.
And it was incredible. And after about 3 minutes, we had no flow. And I didn't believe it. So I did it twice. And I put valves in, and he did amazingly well.
Oh, that's interesting.
So what is really amazing is, I didn't show you this data just because I didn't want to spend too much time on this. Olympus company made their own study, which is called Improve trial. We were part of that in 2018. I was actually the PI for the trial. Same idea, heterogeneous emphysema, but there's one important difference. The aspiration Olympus guys do not have the Chartis machine because they didn't use it in their clinical trial. Their clinical trial was 90% and above on the fissure, right? And then you get included. So they never did this physiological assessment. And it was a positive trial. And they said, look, our trial was positive. We never bothered with this Chartis. Why do you need to waste time and money and do the Chartis? The one problem is that we don't know the distribution of those fissures. We know they were more than 90%, but were they 100% or were they 91%?
Right.
Because 100% is very different than 90 in this line of work. So, but a lot of centers that are not using the charts, and they go based on that trial, and they will just put in valves if your fissure is more than 90%. And I really think that is not the best approach. And I've had numerous cases in my own practice, my own limited experience, where in other words, that guy with 80% wouldn't have gotten included. And many patients that are more than 90 would have gotten valves with no benefit. So that is, I think, an important distinguishing feature, because not every program follows the same protocol. But I do think that it is very important to use the Chartis because there is really a discrepancy between CAT scans and physiology.
Yeah, it's pretty convincing.
Yeah.
Hi, Dr. Shostak. This is one of the fellows. So I had a question regarding the same thing with Chartis. How much of an effect that does air trapping have on the evaluation with Chartis? And does it give you any kind of false positives, meaning there's no collateral, but you see some kind of flow with air trapping, and that kind of makes you decide whether the patient can have the valve or not?
Yeah, sometimes it's a good question. If you do lower lobes, right, because valves go anywhere. So in the lower lobes, you have this phenomena that has to do probably with maybe air trapping, or maybe just maybe just distal atelectasis developing, where the flow will go down and then it sort of starts to choke and click, because basically there's no flow coming back, and you're not sure, is it really because the fissure looks good, or is it because you have this distal atelectasis settling in, especially in the lower lobes by the diaphragm? It's a little bit confusing sometimes to be comfortable in that area. So lower lobes potentially could be tricky for that reason. But again, I think it has to do with the lower lobes, being by the diaphragm and being more prone to this atelectasis formation. We know, for example, from the data that was done on cone beam CT scans, right? There's actually been a lot of data that came out in the IP journal and other journals that looks at doing lung biopsies with cone beam CT scans, and they've demonstrated very nicely that in just a few minutes after putting someone on a vent, intubating someone, with the patient being supine, you develop significant atelectasis in the lower lobes. We know that from the lung biopsy papers. So that we see here. If you're gonna determine lobar perfusion. I'm sorry, if you do the charts on these patients in the lower lobes.
So could you detail exactly again how this is done? Is that a constant? What are we actually recording here? Is this pressure or flow?
This is flow over time. Let me go back to. Let me just go back to.
So the flow goes down to 0 and then it comes back up again.
The flow. This is expiratory flow, which is the top image. Flow, which is ml per minute, graphed over time in minutes, right? And this is like 3 minutes 7 seconds. The flow will disappear because the balloon's inflated. And then at the same time, I'm not sure because I'm not used to looking at this graph. It doesn't show up on my machine. But this is reciprocal increase in airway resistance, which is saying the same thing. Now, when you deflate the balloon, which is equally important because you may have interruption of flow for other reasons. Maybe your catheter is up against the wall, right? And that's why there's no flow. So you have to deflate the balloon and you have to prove that the flow comes right back. So then you know that you are.
The balloon occludes the airway, but how is the flow measured?
Because the flow, the balloon has a little thing at the end of it that measures flow, like the Swan-Ganz catheter.
So it has a thermistor that measures flow?
Yes.
And the flow is going around the balloon?
The flow is going, not around the balloon because the flow is measured at the tip of the balloon. So the little sensor is, I don't know, like a millimeter beyond the balloon.
Right, so which way is the flow going?
The flow is going from distal towards you. Because, so let's imagine this is left upper lobe.
Yeah.
And let's imagine you block the whole left upper lobe, right? So this is upper lobe that's blocked. So there should be no flow heading down the left upper lobe because it's blocked. However, if the left fissure is interrupted, then air is going to come in from the lower lobe through the fissure into the upper lobe, and it'll be then encountered by the sensor. So essentially, when you deflate the balloon, then, I mean, obviously at that point, if you have a complete fissure, then there is no flow going to the left upper lobe. So that's represented by this graph here.
I mean, I was familiar, I've done experiments in the past where we've wedged bronchoscopes into lungs and put a flow in through the bronchoscopic port. And if there's collaterals, then, the pressure doesn't go up because the air just goes out through the collaterals. But if there are no collaterals, then the pressure increases because the flow can't leave. I'm still not sure which flow we're talking about here if the bronchus is occluded. So this device does not inject anything into the airway. It just has a thermistor on the end of it.
Correct.
Okay.
Correct. There's no injections of anything. It's really just a balloon with a thermistor. That's
I think what might be happening is that the balloon does occlude the airway and it might prevent gas from going in during inspiration. But then during expiration, or the gas goes to the other parts of the lung, then if there's there might be an expiration around the balloon, and that's what the thermistor is detecting. And as the lobe deflates, then that flow goes down. Anyway, I'm really curious as to exactly how that works.
Yeah. I mean, my understanding is that thermistor is located right over here by where the green tip is. That's where we see it.
I agree, that's what it's looking at. That's just measuring a temperature change, and it could be measuring it because gas is flowing over it. So,
Yeah.
okay.
Dr. Sorry, one more question regarding, you said the FEV1 does go up after the procedure. Now, is there any changes in the FVC? Does it go down, and does that cause some kind of improvement in the ratio and the curve?
I don't have right now the data in front of me from the Liberate trial exactly, but we can look up afterwards the exact numbers for FVC. I remember the FEV1 numbers. So I mean that is that's the perceived that was one of the variables that was looked at. I don't recall the FVC. I don't know. I can't remember if I put it in the slides. This is just FEV1. Yeah. All right. So I mean, I think it's I think it gives some of these patients a lot of options, but the real problem is patients who are excellent candidates, but unfortunately they don't have the fissure, and that is one of the biggest exclusion criteria that I'm seeing now, and we don't have an option right now for those patients. There's some clinical trials in Germany that will be studying on how to get around the collateral ventilation issue, but we really don't have an option for those patients right now. But I think that is, once you select them on the PFT criteria, that is probably the biggest exclusion criteria that I see. All right.
All right, thank you very much for an excellent talk.
Yes, thank you.
It was very.
Thank you.
Thank you.
Thank you, guys. Be well.
Good evening.